Welcome to this first webinar on behalf of the Global Health Working Group of the Trials Methodology Research Partnership. The Trials Methodology Research Partnership was established in 2019 and is funded by the UK Medical Research Council and National Institute for Health Research. The partnership builds on the achievements of the UK MRC Hubs for Trials Methodology Research Network and will explore further collaborations and avenues to make continued progress in advancing trial methodology, developing capacity and reducing research waste. It will do this by bringing together more networks, institutions and partners working in trials and trials methodology research. Global Health is a new working group established by the University of Cape Town, University of Oxford and Liverpool School of Tropical Medicine. Our vision is to raise awareness of the field and scope of clinical trials methodology research in low middle income countries. We want to signpost to other working groups of the Trials Methodology Research Partnership, increase capacity for clinical trials methodology research through freely accessible resources, training and networking, and facilitate small pump priming grants for low middle income countries, supporting other collaborative projects or grant applications. Ultimately, we want to establish a community of practice for clinical trials methodology research in low middle income countries, as these are underrepresented in clinical trials methodology research currently. Much of our communication will be through the Global Health Network. This is a digital platform for knowledge mobilization in global health, which has a large reach within low middle income countries and was established over 10 years ago and has been supporting researchers to enable easier, faster and better research in the world's most challenging settings. Please do visit our webpage, Global Health Methodology Research, and follow our Twitter account as we build this community of practice. I'd now like to introduce our speaker. Anna Rosala-Hallas studied mathematics as an undergraduate and then did an MSc in medical statistics at the London School of Hygiene and Tropical Medicine. Since graduating, she has worked as a trial statistician in the Liverpool Clinical Trials Centre and has been involved in a number of methodological projects. She has a keen interest in global health and will present findings from a priority setting exercise for methodology research in lower middle income countries. This is intended to inform further research and ultimately to improve trials in these regions.
Great, and thank you so much for having me. So I'm going to talk about a project I worked on which aimed to create a global health trials methodological research agenda. Okay, so firstly I'd like to acknowledge my co-authors who also comprise the steering committee for this project and the MRC who funded the project. And I'll start by giving you a quick overview. So I'll start with a short background explaining what trials methodology is and giving some examples of research that has already been undertaken. I'll then talk about our project, the Global Health Trials Methodological Research Agenda, which was a priority setting exercise. I'll go through the aim, methods, results and discussion and give a few examples of where the research is going at the moment. And I'll end with a short summary. So the background is that we know that clinical trials are regarded as the gold standard for estimating treatment effects. But we also know that trials take a long time to recruit patients, to collect data, follow up the patients, to analyse the data and to report. And they're also expensive. So if we have one chance to test a treatment or an intervention, it's important that we get it right. Okay, so that brings us on to what trials methodology is. Well, this is any research that investigates the methods, practices, and procedures that are used for the 4 stages of the life cycle of a trial. That is, the design, conduct, analysis, and reporting. I'm going to list a few projects from the Northwest Hub for Trials Methodology, and references for their corresponding papers can be found at the end of the presentation. And hopefully this will make it a little clearer of what we mean by this type of research. So the first is a project that looked at the best way to recruit to paediatric trials. So this is an example of research into the processes to aid recruitment to trials for particular groups of patients. The second was a review of patient information leaflets to see how the importance of follow-up was communicated to patients. So here we're looking at methods to reduce attrition to trials. How can we ensure that participants don't drop out from follow-up? The third is a more practical example. This project was looking at an analysis of the delays in opening trial sites. So what stops sites in trials from opening on time, and how can we avoid it? Or perhaps the research is to do with statistical analysis, so maybe modelling different types of data within a trial setting. For example, the project referenced here used joint modelling methods to account for informative loss to follow-up. And finally, it could be research to do with the reporting of trials, like this example, which was to do with reviewing research funders' guidelines on reporting. And if you're interested, there are loads more examples that you can find online on the MRC Hubs for Trials Methodology websites. So clearly, we can see that there's a vast amount of methodological research that can be done and is being done. But in order to focus on the more important issues, some prioritization is necessary here. Between 2011 and 2012, a priority setting exercise was undertaken in the UK in order to establish what the priorities were for trials methodological research. An online Delphi survey was undertaken by 48 UK clinical trials unit directors to find out what topics they felt were important and needed. The top 3 priorities identified were methods to boost recruitment, choosing appropriate outcomes to measure, and methods to minimise attrition. This was published in the open access journal Trials in 2014 and has since been cited over 50 times. So we know that these topics are important in the UK, but we can't assume that these priorities hold for other high-income countries, and also not for low to middle-income countries, where there are differences economically, politically, and culturally. We know that low to middle income countries, or LMICs, are underrepresented within this field. The 2013 World Health Report advocated for LMICs to become the generators rather than the recipients of research, in order for effective and relevant research to result in public health outcomes. So the aim of our project was to begin facilitation of this by providing the first steps towards an agenda for trials methodology research in LMICs. And to do this, we wanted to identify what were the top priorities. So we conducted a 2-round online survey between December 2016 and April 2017. We emailed researchers who had had involvement in the design, conduct, or analysis stages of a trial with an invitation letter explaining the scope of the project and giving a hyperlink to an online survey. The survey was conducted in English, however, we also attached translations of the invitation letter in French, Spanish, and Chinese in order to improve understanding where there may have been language barriers. We distributed our survey and invitation letter to the Global Health Network, the EDCTP, and other networks that were identified via the co-authors. We also searched on clinicaltrials.gov for trials currently ongoing in LMICs, and we contacted the investigators working on them. We also encouraged respondents to pass on the survey to anyone they knew that might be interested. So round 1 of the survey began by asking participants to complete some questions, giving information about their background and involvement in clinical trials. We then asked them to suggest 3 to 6 priorities for methodological research in LMICs. We categorised all the free text responses and made a list of topics. Our categorisations were reviewed by our steering committee. We decided to split the topics into 2 lists, given the high number, in order to decrease participant burden in round 2 when we asked respondents to review and grade each topic, so that we could ensure we had a high response rate. The primary list of topics consisted of those suggested by 4 or more respondents, and the secondary of the remaining topics. To increase completion, we made the first list compulsory and the second optional. And in round 1, we also asked the participants if they'd like to be contacted for round 2, and if so, to provide us with an email address that we could contact them on. In round 2, we contacted those who had provided their email address and asked them to grade the topics in each list from 1 to 9 using the grade guidelines scale. A score of 1, 2, or 3 indicated that the topic was not important to them. 4, 5, or 6, the topic was important but not critical. And 7, 8, or 9, the topic was critically important. We also provided an incentive, so participants who completed both rounds were entered into a prize draw to win travel and accommodation at the Joint International Clinical Trials Methodology Conference and Society of Clinical Trials 2017 conference, which was held in Liverpool in the UK, and where we presented a poster of our results. Our prize winner was a research nurse from Peru. So onto the results. 826 people accessed round 1 of the survey. 15% indicated they didn't have any experience working in clinical trials, so they stopped there. Of the 702 who did have trials experience, 41% only provided information about their background and didn't provide any topics. The remaining 59% completed the survey. For round 2, we contacted the 378 people who had provided their email addresses, of which 83% responded and completed the round. Now, some information about who took part. Our respondents represented over 80 countries in round 1. 51% said they were currently residing in one of the countries in Africa, 20% in Asia, 16% in Europe, 8% in South America, 6% in North America, and we even had one person from Australia. We were interested in where respondents gained their trials experience, and we found that over 85% of respondents gained their experience working in an LMIC. Our respondents had a median of 5 years of experience working in trials, which ranged from 1 year to 45. Most reported involvement in the conduct of trials. However, over half had experience in each stage of a trial. The majority of respondents were from a clinical background, so for example, public health, infectious diseases, general medicine. But 21% came from a research methods background, so that's trial management, statistics and data management. 9% from a laboratory sciences background, that's biomedical sciences, pharmacy and parasitology, and 5% came from another background. We also asked these same background questions for round 2, and we found that this subgroup was similar in terms of characteristics to those in round 1. So moving on to the topics, overall 1,620 items were suggested. We had to exclude 43% for being too vague or beyond the scope, and we put some of this down to misunderstanding, perhaps due to language barriers. We split the remaining 917 topics into list 1 of 27 topics which were suggested by 4 or more respondents, and list 2 comprising the remaining 55. We also reviewed the topics identified in the UK study, but not the current study, and the steering committee chose to add 2 of these topics to list 2, which were the design and analysis of feasibility, pilot trials, and equivalence trials. The results from round 2 showed that the top priority, of which 92% had graded as critically important, was choosing appropriate outcomes to measure. This was also in the top 3 priorities for the UK, and in a couple of slides, I'll talk a little more about this one. In second place was training of research staff. And in settings where resources are limited, it's really important that the most cost-effective ways of achieving high-quality training are used. I'll also touch on some of the reasons that this was chosen in a couple of slides. Other topics identified were strategies for adverse event reporting, methods for data capture, methods for data management, etc. And you can also find the results for list 2 in the publication. So over half of the topics scored as critically important by 80% or more respondents on both lists 1 and 2 were to do with the trial conduct. And this could have reflected the sample of our responders, so most of them had said that they had had involvement in conduct. Boosting recruitment and reducing attrition were the 2 other top topics in the UK study. However, these weren't felt to be as important in the LMIC study. Perhaps recruiting people to take part in a trial and keeping them in follow-up isn't as much of an issue in LMICs, as maybe taking part in a trial means that participants are guaranteed access to healthcare as part of their follow-up, which might be more than they have ordinarily. Or perhaps the interventions aren't actually available outside of a trial setting, so people are more inclined to consent. So this really reflects the differences in priorities between the regions. In order to find out a bit more about why respondents felt each topic that they suggested was important, we gave them the opportunity to give a reason for each topic. So for our top priority, some of the reasons given were it's the main backbone of the study. Quality of life, for example, in cancer patients, is an area that lacks attention in LMICs. The question will guide the research. If the objectives are not clear and cannot be used to define endpoints, then the study is a waste of time and money. Reasons for choosing training of research staff included: in LMICs, we have little purposeful training for people to engage in research settings, and there are few people who know the importance of clinical trials and recognise the need for specific training. Staff who are well informed or trained contribute to the success of the study. Because most clinical trials are designed in high-income countries. And I observed that training for support staff is often limited to GCP and a bit of trial-related didactic training, and that there may be a better, cost-effective way, for example, blended learning, to increase competencies and support them in their clinical trial careers. Now, is anything already being done? So an example of ongoing research for our top priority, choosing appropriate outcomes to measure, is the COMET initiative. More information is available on their website, but in brief, COMET aims to increase core outcome sets, which are agreed standardized sets of outcomes that should be measured and reported as a minimum in all clinical trials in specific areas of health or healthcare. Up until the end of December 2018, only 18% of core outcome sets included participants from LMICs, so there is still a need for further engagement. Recent work to improve and increase global core outcome sets is ongoing. For example, Jamlik is a PhD student for the MRC NIHR Trials Methodology Research Partnership Project, and his research focuses on improving the uptake of core outcome sets in LMICs. More information on his project and others can be found on the COMET website. Meanwhile, in China, in July 2019, CHICOS was established, which is the Chinese Research Centre for Clinical Trial Core Outcome Sets. The aim of this centre is to provide methodological support to core outcome set developers in China. And there is also now ongoing work to develop core outcome sets for COVID-19, which will involve a number of global participants. So, in summary, trials methodology research is any research which investigates the methods for the design, conduct, analysis, or reporting of clinical trials. Having this research is essential to ensuring trials are well conducted and cost effective. Although priorities have been established in the UK, these differ to those in LMICs, and an extension of this work would be to make this more specific for different regions and countries. So priorities in Asia are likely to be different to those in South America, for example. The top priority from this study was identified as choosing appropriate outcomes to measure, and work is currently ongoing on core outcome set development through the COMET initiative. So thank you for listening.
Thank you very much, Anna, for your presentation. That's great. I'd like to let those listening to this webinar know that you may post comments and questions below, and we will aim to answer these over time. Please do look out for our next webinar, any other webinars from the Trials Methodology Research Partnership, and please do browse the many trials-related resources on the Global Health Network. You can also join the Global Health Working Group as a member. Please see the Trials Methodology Research Partnership or the Global Methodology Research websites for more details. Thank you very much.